Think we can go ahead and get started. I see people joining us on Zoom, and then we have an audience here in person as well. So thank you everyone for joining for our second cardiology grand rounds of the new academic year. And it's really, again, my name is Evelyn Song. I'm one of the third year cardiology fellow and the chief fellow who's helping to lead cardiology grand rounds this year. So today we have Dr. Janet Wei joining us from Cedars. It's really my great pleasure to introduce her to everyone today. Dr. Wei completed her internal medicine residency and cardiology fellowship at Cedars, followed by an advanced training as an NIH T32 trainee at the Barbra Streisand Women's Heart Center. Her clinical and research interests span among cardiovascular disease in women, preventive cardiology, coronary vascular dysfunction, and advanced cardiovascular imaging. Dr. Wei is truly accomplished and very a true leader in field of women's cardiovascular health. She serves as the program director for the Cedars-Sinai Cardiology Fellowship Program, co-director of the Stress Echocardiography Lab, and associate medical director of the Biomedical Imaging Research Institute at Cedars. In addition, she also hosts the prestigious Erika Glazer Chair in Women's Cardiovascular Research. Dr. Wei's work also extends beyond the clinic as she served on important national committees like the ACC's Cardio-OB work group and the California Pregnancy Associated Mortality Review Committee. And she collaborates closely with obstetricians to advance the cardiovascular care of pregnant and postpartum women. So we're truly fortunate today to have Dr. Wei join us. The title of her talk is The Obstetric Cardiac Patient, Recognizing and Mitigating Morbidity. So now please join me welcoming Dr. Wei. Thank you.
Thank you so much, Dr. Song, for that kind introduction. I really thank you for the invitation, particularly Dr. Goldschlager, I see on Zoom, for being here today. We'll go ahead and get started. So the objectives of my talk today, I hope you'll learn that the significance of cardiovascular disease in pregnancy. We'll review some of the physiology of normal pregnancy and how to recognize signs and symptoms of cardiovascular disease, provide a general guidance for cardiac risk assessment of a pregnant patient, and then outline just very high level some of the key cardiovascular disorders that I think that fellows should know about management of pregnant and postpartum patients. I had really the honor of participating as an ACC representative for the ACOG practice bulletin that was specifically geared towards addressing pregnancy and heart disease, led by the late Dr. James Martin. And it was just an eye-opening experience, really working with MFM specialists, anesthesiologists, cardiologists to try to come together to improve the way that pregnant patients and postpartum patients were being identified. Subsequently, also had the opportunity to work with the Cardio-Obstetrics work group through the ACC, which is now the Reproductive Health and Cardio-Obstetrics member section, led by Dr. Natalie Bello and Dr. Key Park, and it's a tremendous group. If you're interested in getting involved, I highly encourage you to look into the group. And then for the last 3 years, my term ended in December, also had the opportunity to work as the Southern California Pregnancy Associated Mortality Review. And so some of the slides that I share today are from our California Pregnancy Associated Mortality Review Committee. CMQCC is kind of the overarching collaborative, and then also from our work in the Cardio-Obstetrics work group. So why am I giving this talk today? What's the significance of cardiovascular disease in pregnancy? Well, what many people don't realize is that there are millions of women in the United States of reproductive age, 18 to 44, who have cardiovascular disease. And so cardiovascular disease actually affects about 1 to 4% of pregnant women annually. And what most cardiologists and clinicians don't know is that cardiovascular disease is actually the leading cause of death in pregnant and postpartum women in the United States, responsible for about 1/3 of all pregnancy-related deaths, and that includes deaths during pregnancy and up to a year after delivery. What we might not think about is that we may have thought, well, most of these patients may have had congenital heart disease, but actually the majority of these cardiovascular deaths are due to what we call acquired heart disease. So that includes hypertensive disorders in pregnancy, new diagnosis of heart failure, ischemic heart disease, aortic disease, and arrhythmias. On the other hand, congenital heart disease, maternal morbidity and mortality has actually been quite low. It's been quite stable at about 0.5%. But because there is a significant increase in women who are now in a reproductive age who have congenital heart disease, certainly a significant issue. And I'm glad that you guys have such a strong adult congenital heart program here who see these patients. If we break down in the United States, what is this 33% of cardiovascular disease? It's majority a big lump of conditions that is called other cardiovascular disease that includes heart failure, ischemic heart disease, et cetera. Cardiomyopathy, though, is the second leading cause that includes peripartum and also pre-existing cardiomyopathy. And then you can see that hypertensive disorders of pregnancy also is a significant burden, 6.6% in the United States. Each of these conditions kind of present themselves and have a higher risk of mortality at different phases of the pregnancy, some occurring during pregnancy. The pregnancy-related hypertensive disorders tend to occur in that first week postpartum. And then cardiomyopathy, particularly peripartum cardiomyopathy, tends to occur 6 weeks to a year after delivery. But you can kind of see this breakdown that's been reported overall in the United States. There are differences based off of racial ethnic breakdown as well. So while cardiomyopathy, this group of cardiovascular conditions, preeclampsia is the leading cause of maternal mortality in non-Hispanic Black women, you can see that it's a little bit different for non-Hispanic white women, where the cardiovascular conditions come behind mental health conditions that contribute to deaths. In cardiomyopathy, a little bit lower down on that list. Now, what are the risk factors? Some of you may know this because these are also risk factors for general cardiovascular disease, but maternal age greater than 40, we have increasing ages in which women are getting pregnant. And if you are pregnant over 40 years old, you're unfortunately at a 30 times higher risk for cardiovascular death than if you were pregnant under age 20 years. Having a hypertensive disorder of pregnancy, whether that is chronic hypertension preceding your pregnancy or development of gestational hypertension and preeclampsia, unfortunately associated with over 10-fold higher risk for myocardial infarction, postpartum, 8-fold higher risk of heart failure, and then pregnancy obesity. We all know the obesity epidemic does not spare our pregnant postpartum patients. If you have a BMI over 35, you unfortunately are also at a higher risk for adverse pregnancy outcomes and mortality. And as I mentioned before, certain racial ethnic breakdowns that have been further studied don't feel is specifically a racial risk factor, but perhaps related to social and demographic differences. But unfortunately, a very well described racial difference of a higher risk for dying from cardiovascular pregnancy conditions than non-Hispanic white women. Socioeconomic differences, as I mentioned, and then unfortunately, substance abuse, cocaine, smoking, alcohol, and particularly methamphetamine use, highly associated with adverse pregnancy outcomes related to heart disease. So with the rising mortality in the United States and also in California in the early 2000s. In 2006 was really when there was a joint effort from this California Maternal Quality Care Collaborative to systematically review the deaths. And so they looked at deaths from 2002 to 2006, went through very carefully all the medical records, tried to identify a clear cause of death and contributing factors. And then the goal, of course, was to then identify ways and strategies to prevent these deaths and systematically provide more education and toolkits. This initiative was led by Dr. Afshan Hamid, who is a dual board certified OB/GYN cardiologist at UC Irvine. And they looked at about 64 deaths. You can see a very small print, sorry, the breakdown. But the key point of this is that what they found was that major factors contributing to these deaths, there were ones that were related to patients. For example, they had a delay in seeking care or kind of follow-up, literacy, substance abuse. But look on the right side of healthcare provider factors. A significant contribution was delayed response from providers, ineffective care, misdiagnosis, failure to consult or provide next steps, and lack of continuity of care as well. Last year when I was giving this talk to our fellows, we had a pregnant fellow who said, "Oh my goodness, I'm pregnant. I don't want to hear this lecture." So we also want to take a step back that, this is a rare condition, right? Mortality from cardiovascular disease is rare, but so among over 500,000 California women giving birth every year, we do think that about 7,700 have a new diagnosis of cardiovascular disease in pregnancy. A subset of that will be peripartum cardiomyopathy, and majority of the deaths from cardiovascular disease are from peripartum cardiomyopathy. So you can see the numbers are very small, but due to the significant mortality, important to discuss. What came out of that mortality review was to try to come up with an algorithm to help our clinicians, whether it's the primary care, the OB, the emergency room, support staff, to recognize red flags. And so these are the red flags you can see in this table that is supposed to try to gear nurses, clinicians to identify, this is a patient that needs that higher level of care. We need a consultation with maternal fetal medicine, with internal medicine, with cardiology. At the same time, if you determine that a woman who's pregnant or postpartum has a personal history of cardiovascular disease, still reasonable to consult them, particularly if they're presenting with symptoms. And so this was the algorithm that came out of that review, looking at a combination of symptoms that we are all familiar with for potential heart failure, ischemia, looking at high risk vital signs that really are abnormal in a pregnant woman, looking at the known risk factors that I mentioned earlier, and then of course, physical exam findings of heart failure. And so kind of having an integration of these 4 categories to then take the next step in ordering cardiovascular diagnostics, in identifying a referral for cardiology and maternal fetal medicine. And so retrospectively, what they did was they applied this algorithm to those 64 cardiovascular deaths, and 88% of those cases were then found through this algorithm that would have been identified. And if you looked at only the symptomatic ones, then that increased to 93%. So this was something that was then formally recommended as part of a toolkit that was published in 2017 from the CMQCC. And I just wanted to have a shout out to some of your UCSF faculty. Dr. Foster was part of this. And so 2017 rolled out this toolkit that included that algorithm and some other high key kind of management of patients. And then in 2021, also a specific one for hypertensive disorders of pregnancy, which I'll go over a little bit more. So if we look at kind of trends in pregnancy-related mortality in California from the different time points, we haven't made a huge dent in cardiovascular disease as represented by that blue bar, but we have had a significant decline in mortality related to hypertensive disorders of pregnancy. And I think it's because of these mortality reviews and providing more standardized algorithms for OB teams to implement quickly. So taking a step back, why is pregnancy associated with increased risk for cardiovascular disease? Well, there are significant hemodynamic and structural changes that occur in a pregnant woman's body, and it's considered our natural stress test. And so looking at this figure going from pre-gestation to the different trimesters to delivery, there are significant increases in cardiac output, up to 50% higher, increases in blood pressure, changes in heart rate, and then decreases in systemic vascular resistance that may potentially exacerbate underlying cardiovascular conditions or may unveil underlying conditions throughout the pregnancy. This is the table from the ACOG practice bulletin that we put together, and just kind of gives a little bit more of the numbers associated with each of the trimesters. And you have to recognize also in that stage 1 and stage 2 labor, when you've got the uterine contractions, there's dynamic increases in blood pressure and shear stress. And most importantly, in that early postpartum period, once the placenta is out, there's this auto transfusion, about 500 milliliters of blood goes back into the woman's body. It's like a little bolus of fluid that you have to think about in your patients who are at risk for heart failure. There's so many dynamic hormone fluctuations and fluid shifts that occur in that early postpartum period. And it really takes 3 to 6 months before the heart kind of goes back into its pre-pregnancy values. And for some people, it never fully returns back to pre-pregnancy state. As part of that physiologic change and adaptation to pregnancy, there are transient changes in the chambers. All of the chambers will dilate from 10 to 15%. Left ventricular mass will increase up to 25, even up to 50% in hypertensive patients. And so this is important to know. We usually don't anticipate, though, when we're reading echocardiograms of pregnant patients, for a healthy person to reach pathologic, thresholds when you're reading the echo, but just something to think about, that you can see slightly increased chamber sizes, thickness, and even some trace to small pericardial effusions may develop. So when we think about what is the best way to manage these patients, we try to determine what their cardiovascular risk is. And what I'll show in the next slide is a modified WHO pregnancy risk classification that is now standardized, so that it's good for you to kind of know and think about when you're evaluating any pregnant or postpartum patient. And depending on that risk is helps you gear towards what type of specialists need to be involved in the care of this patient. And so you can imagine the higher risk patients really need a more comprehensive team and really should be delivered at facilities that are able to take care of all their specialized considerations. I know this is a very busy table. You can find this in the resource I'll share later. But the key thing is that there are different categories of cardiac conditions that are associated with varying risk throughout the pregnancy and postpartum. One that gets tested for cardiology fellows is the class 4, the pregnancy contraindicated. So just know that as at the minimum. But other things to think about is the ejection fraction, congenital heart disease is on this, aortic stenosis, mitral stenosis, LV outflow, tract obstruction. But the WH class 4, where we recommend pregnancy contraindication, are pulmonary arterial hypertension of any cause, ELV, systolic dysfunction, less than 30%, or other NIH class 2 to 4 conditions, those who've had prior peripartum cardiomyopathy in which they didn't actually recover their LV function, severe LV outflow obstruction, mitral stenosis, and you can see the list goes on there. So unfortunately, some of these patients don't come to us before pregnancy, right? We're unfortunately faced to deal with their cardiac conditions when they show up to us while they're already pregnant. And so in these patients, though, you want to be able to give that very well-documented patient discussion about whether termination should be considered. Another risk prediction model that has been used is the CARPREG-2 risk model. You can see here, gives you a way to estimate a risk for a patient. There's also another one for adult congenital heart disease, which is the Zahara. And so these are different ways to provide a little bit more of a discrete number for patients. But ultimately, every patient is a little bit different. Their values are different. So there really needs to be that team-based discussion and care. Ideally, if we can capture them before conception to talk about contraception, making sure their medical status is optimized, determine if they need to stop any of medications when they become pregnant, and have that discussion documented. And then you can see at different stages of their pregnancy, delivery, postpartum, also to have a plan to address each of these stages. So when patients come to our cardio-OB clinic, we want to try to have that outlined for each patient. And then we never want to forget about the postpartum state, that fourth trimester, is that they are at significant higher risk for adverse outcomes, and that we need to make sure that these patients are getting the follow-up that they need soon, for some patients sooner than others. And then what we've learned is that certain women who have hypertensive disorders of pregnancy, who have preterm delivery, unfortunately, that those conditions are associated with higher risk of maternal cardiovascular disease, higher risk of hypertension, ischemic heart disease, heart failure as early as 2 years postpartum. So it's not like it's 10 years, 20 years down the road. At Cedars-Sinai, we do have a multidisciplinary team of MFM specialists, adult congenital, pediatric congenital, anesthesiologists, and then kind of our women's heart program, where we try to develop these plans. We have weekly team meetings where we talk about patients that we're seeing to make sure that everybody's kind of on the same page. And these patients do see our OB team also around 30 weeks, also to have an OB plan about what they're going to do in terms of the peripartum care of these patients. Very quickly about contraception, this may be a little bit hard to see, but depending on their underlying cardiac condition, you also want to be familiar with what type of contraception is considered safe, with certain contraception, particularly with the systemic estrogen, higher risk of thrombosis. So you can imagine that certain conditions here, you would want to avoid that systemic therapy. In general, the IUDs are safe, and progestin-only pills are safe, but you can see that there are varying conditions, and some of it is lack of data, but this is from a consensus statement from the Cardio-Obstetrics work group. Now, who hasn't heard of a pregnant woman who says, "Oh, I'm tired. I'm a little short of breath. I have some swelling in my legs. I might be feeling some palpitations." Part of this is the more natural physiologic changes of pregnancy. And so it's very important for us to educate clinicians about how to distinguish what is considered normal pregnancy symptoms and signs from pathologic. So this was some kind of like a nice green, yellow, red stoplight to help general clinicians kind of identify, right, this is something that we can provide reassurance. But really, when they're having, for example, syncope, particularly if it's exertional and unprovoked, if they're having really extreme fatigue, signs and symptoms of heart failure, tachycardia that's above 90 beats per minute, that's something that requires cardiologists to take a next step. Tachycardia can sometimes present as the main symptom for peripartum cardiomyopathy. So having an eye for looking out for cardiovascular conditions is important. I already addressed this figure, but this is something that we published in that ACOG bulletin to try to help clinicians to determine, all right, what's the pathway to referral for cardiology testing. So the main conditions that are associated with higher risk of morbidity and mortality in the pregnancy and postpartum state is cardiomyopathy, left-sided valve stenosis, obesity, pulmonary arterial hypertension, and hypertensive disorders. And you can see in the middle, there's all sorts of cardiovascular complications that we need to know how to manage when they come to see us inpatient or in outpatient. And we have to kind of have a plan to tell our team, all right, I'm going to put them in the CCU, or I'm going to put them on telemetry, or I'm going to make sure that I diurese them early postpartum, or I'm going to put in an A-line. So those are all the decisions that we have to provide for our team-based care. I think that sometimes we don't always think about this in all of our pregnant patients, but it's just very important to have that plan. And it's evolving plan. Sometimes you change your plan. What's the data for BNPs? B-type natriuretic peptides are not normally elevated in pregnancy. We have some small data sets that show, though, that in preeclampsia, they do become elevated. And often we'll get an echocardiogram because they might be presenting with some shortness of breath. And patients with severe preeclampsia can have really high BNPs. You might think that they are having peripartum cardiomyopathy, maybe in the 500s even, but not necessarily due to peripartum cardiomyopathy. And in pregnant women, BNP and NT-proBNP does predict cardiovascular outcomes and seem to correlate with filling pressure based off of echo studies and very limited imaging. One of the things that is always sometimes a sticking point when we're discussing tests, blood test is easy, right? Echo is easy, it's non-invasive, no radiation. But what about our other options for cardiodiagnostic testing? So when we're having that shared decision-making conversation with our patients, we have to keep in mind that in general, if it helps the mother, it's going to help the baby. And so sometimes I think we're a little bit under fear, especially in our lawsuit-prone, environment about what are the fetal risks. But you have to keep in mind, if we're going to improve the condition of the mother, we're going to improve the condition of the baby. Now, there are certain things that we have to think about: radiation exposure, teratogenicity from medications. But ultimately, I want to kind of emphasize that ultimately, most things that help the mother are going to help the baby. And if we think about radiation, this is kind of a nice table that I hope you'll kind of put things into perspective, is that yes, there are studies that are associating radiation, quite high radiation, 50 to 100 and above milligrays, where there may be some malformation risks, spontaneous abortion, potential IQ deficits. But if you compare that to the actual fetal dose of radiation that we typically do for our cardiovascular testing, it's really small. And there are ways that we can shield the baby with our various tools. So just keep that in mind when you're having that discussion about whether to order that CT chest to rule out PE, for example. In most cases, you're going to go ahead and choose the imaging test. What about cardiac medications? Approximately about a third of cardiac patients will require medication during pregnancy. So you do have to think about whether the medications that you're choosing are teratogenic and whether they need to be stopped before pregnancy. This is something that comes up, of course, with our heart failure patients or our hypertensive patients who are on ACE inhibitors and ARBs. If there are certain medications that may have some potential teratogenic effects, but you really think that this is going to be key in keeping them hemodynamically stable throughout their pregnancy, then you do have to have a good documentation and discussion with the patient and make sure that that's specifically outlined in your notes. We tell our patients not to stop any medications for their heart conditions until they have reviewed it with our care team. Sometimes patients will think, oh my goodness, I have to stop everything, and then potentially can decompensate. So having that discussion with them ahead of time ideally is key. About 10 years ago, the FDA recommended no longer to use their classic A, B, C, D, and X categorization of safety of medications for pregnancy and lactation. And now it's just lists of what the data is. And so that was intended to try to encourage clinicians to have a little bit more leeway in prescribing medications where the data is not always so clear. And then LactMed is a database by the NIH that is a good resource for breastfeeding safety that encourage, if you have questions about medications, it's a great resource. Now, we talked about some very briefly like cardiac medications that could have consequences, but what are the obstetric medications with cardiac consequences? Not unusually, or it's common, these are common medications that are used in the delivery or management of pregnant patients. Steroids are often used for fetal lung maturation in preterm babies. And so theoretically, there can be some transient increases in blood pressure or fluid retention. Oxytocin, used commonly for labor induction, usually given as a slow IV infusion. If given as a rapid intravenous bolus, it can contribute to arrhythmias and hypotension. So if you are trying to avoid that, that's what we tell them, don't give a rapid IV bolus. Magnesium, of course, used in the setting of preeclampsia, eclampsia, can also lower the blood pressure. It's a vasodilator. And of course, for some of our patients with LV outflow tract obstruction, left-sided valve disease, we do have to be a little bit careful with that. But in general, patients do well. It can also contribute to bradycardia, so just caution in patients with heart block. Terbutaline is a beta mimetic used to delay preterm labor. So for our patients with arrhythmias, we would say try to avoid contributing to their tachycardia and arrhythmias. Methergine or methyl argonavine is used for postpartum hemorrhage, sometimes used to prevent postpartum hemorrhage if they feel like there's a boggy uterus. If given intravenously, it can contribute to coronary vasospasm and arrhythmias. But there are IM ways and other non-IV ways to deliver it. So if that's something that you think that the patient should not get, you would make that recommendation in your notes. And then lastly, just kind of another one, sometimes I've seen hemabate or carbopros, which is also used for refractory uterine bleeding. Unfortunately, we should try to avoid in patients with pulmonary hypertension and cyanotic congenital heart disease. So our adult congenital team will usually use an alternate. As I mentioned, we work closely with our OB team to determine what type of care that they need. Like say they do need a C-section. Sometimes the question is, oh my goodness, do I need to have an intra-op TEE? Do I need to have a PA catheter? Do I need to have a A-line? And for majority of conditions, the answer is no. But certainly if you've got someone who has significant LV output of LV outflow tract obstruction, stenoses, or other conditions where you really want to keep their blood pressure well controlled, then an A-line can be easily, given. Most situations, cardiac conditions do not require C-section. Most conditions are well tolerated with vaginal delivery, and you can offer epidural analgesia to try to reduce the catecholamines associated with the stress, neuroaxial anesthesia if possible. However, if patients are on anticoagulation, then they won't be putting in an epidural in certain situations. And so you have to make that decision with the patient. There are even more detail regarding the ways neuroaxial anesthesia is given, depending on how quickly things are administered, slow infusions. And this is more pertinent for those with LV outflow tract obstruction, where you really want to avoid the hypertension that's associated with the anesthesia. So taking a step back, we talked a little bit about, things that we want to cover: preconception in terms of contraception, medications, peripartum and postpartum monitoring. There's more interest nowadays, particularly as cardiologists, about, well, what does that cardiovascular experience in pregnancy, how does that relate to their future maternal heart health? And a lot of scientists are trying to understand that. This is a nice figure that Dr. Natalie Bello put together that shows that we still don't fully understand why certain conditions are associated with increased cardiovascular risk, but certainly hypertensive disorders, preeclampsia, associated with a higher risk of hypertension, cardiovascular disease, ischemic disease, stroke, heart failure, diabetes. But there's a lot more to be learned in this field. When we try to apply these adverse pregnancy outcomes into risk calculators, for example, try to combine them with pool cohort equations, unfortunately, it doesn't really add extra risk stratification. So there's, I think, more room for us to learn how to consider this, but it is now part of that risk enhancer, list that you do when you're assessing a patient for their cardiovascular risk. And I think most important is any woman that you see, ask them about their reproductive history, ask them about how their pregnancies went, ask them if they had early menopause, difficulties with fertilization. So now for the next few minutes, I just kind of want to highlight 2 to 3 kind of key concepts about the management of certain conditions. It's by no means comprehensive, but things that I think are important. Now, with the aging population of women who are getting pregnant, some of them are going to have pre-existing coronary disease. And when they have pre-existing coronary disease, they are unfortunately at a higher risk for heart failure, recurrent ischemic events, arrhythmias. And we do want to encourage our pregnant patients to delay pregnancy after an acute myocardial infarction at least, a year. So for some of our more common conditions that occur in women, like spontaneous coronary artery dissection, we'll talk a little bit about that later, but we definitely, if they even are considering pregnancy, we want them to wait at least 1 to 2 years. Statin therapy is still controversial. Statin was removed from, or was recommended to be removed from that black box warning by the FDA because there may be patients that will benefit from statin therapy in pregnancy and postpartum. But for most patients, because statins are associated with some increased risk of spontaneous miscarriage and potential concerns about cholesterol, synthesis in the fetus, in general, most people will discontinue their statin unless they're very high MI risk. Patients with familial hypercholesterolemia who do not have prior ischemic events, statins will most often be discontinued in those cases, and they may consider bile acid sequestrants or even LDL apheresis as an alternative. We talked a little bit about SCAD, which I'll go into a little bit more. And for our ischemic patients, if they're heavily having angina during pregnancy, there are some patients that during the active phases of labor that they will have an exacerbation of their chest pain. And so this is when we encourage them to have the epidural to try to minimize the catecholamine surge and shear stress, and then to consider a assisted second stage of labor using using suction or vacuum forceps, and try to minimize that Valsalva effort. For those who are interested, there are some suggestions also for the anesthesiologists, if they're hypotensive with anesthetics, to consider phenylephrine, to titrate oxytocin carefully, as I mentioned, and to consider ECG monitoring, particularly the ones that are higher risk, and to avoid the IV methylargonavine because of the increased risk for vasospasm. What about cardiomyopathy, with also, all the different variations of cardiomyopathy that may pre-exist in a woman? Certainly, when we have an aging population, there's also more obesity, more hypertension, and all of these extra factors, unfortunately, will increase their risk for death and heart failure or decompensation. Unfortunately, having that pre-existing cardiomyopathy is associated with increased risk of arrhythmia as well during pregnancy. And so what do we do with them? Well, fortunately, most of the care is similar to a non-pregnant patient, with the exception that, yes, we don't use ACE inhibitors or ARBs or ARNIs or MRAs while they're pregnant, but once they've delivered, we can use these medications, and some of them are safe in breastfeeding. And I'll talk a little about PPCM a little bit later. What about arrhythmias? Very commonly, we get pregnant women with palpitations, and then you have to kind of counsel them, is this something serious or not? In general, if they are having arrhythmias, we'll want to identify what it is. The most common arrhythmia during pregnancy are just premature atrial contractions and paroxysmal SVT. But older women who are pregnant do have a slightly higher risk of having atrial fibrillation or flutter. We rarely see ventricular arrhythmias, although those who have RVOT tachycardia or CPVT, where you can get arrhythmias in the setting of higher catecholamines, that sometimes presents in pregnancy because of those physiologic changes that I mentioned. And then, unfortunately, those women who have long QT, they should stay on their beta blocker, including throughout the postpartum state, to reduce their risk for ventricular arrhythmias. What about the medications that we use? We are, ACLS guidelines fairly open to all of the management that we have to non-pregnant patients, with exception for stable monomorphic VT rather than reaching for amiodarone because of theoretic potential problems with thyroid toxicity in the fetus. Preference for sotalol and IV procainamide. But amiodarone still, if you've got unstable VT, don't hesitate to use that, of course. For cardioversion, sometimes women are concerned, like they're worried about their fetus's heart, their baby's heart. And in general, follow ACLS guidelines. If you have time to put on fetal monitoring, you can certainly do that and monitor them post cardioversion. But don't delay the cardioversion, of course, if they're unstable, and you can always call them to come by to put it on afterwards. Okay, what about acquired heart conditions? So as you saw in that figure about the leading causes of death, hypertensive disorders of pregnancy, while the mortality risk is decreasing in California, unfortunately, it's still quite high across the United States and certainly high in the African-American population. And hypertensive disorders of pregnancy is very common, 5 to 10% of pregnancies. Peripartum cardiomyopathy is much less common. Ischemic heart disease, much less common. Aortic dissection, really more to worry about in our patients with Marfan, bicuspid valves, Ehlers-Danlos, et cetera. And then very rarely prosthetic valve thrombosis. So I heard from the fellows yesterday that that because OB delivers in a different center, that maybe you don't have as much exposure to hypertensive disorders in pregnancy. This is actually one of the most common reasons our cardiology consult service gets called is a postpartum or pregnant patient who they're just having a hard time controlling their blood pressure. And there's a whole spectrum of hypertensive disorders, but fortunately the ACOG has very good algorithms for the OB team to follow to say, all right, this is the interim blood pressure monitoring that we want to do for hypertensive patients, very quick action when their blood pressure is over 160 over 110. And the key medications that they will reach for are the IV labetalol, IV hydralazine, and then what's particularly useful if the patient doesn't have an IV yet is PO nifedipine, the short-acting nifedipine. So there's a whole algorithm that they will follow. But sometimes they will still be hypertensive and they might come to the unit for intravenous medications, continuous drips, and then they'll want your help in titrating their medications afterwards. So what are kind of the key things that you need to know about preeclampsia? Onset, preterm preeclampsia, particularly very early preeclampsia before 34 weeks is often severe. And so these are the patients that are often getting delivered early as well. If they don't have severe features, then induction of labor at 37 weeks is fairly routine. And the idea is you don't really want to sit on someone who is having preeclampsia because they have a higher likelihood of fetal loss. What is the diagnostic criteria for preeclampsia criteria, which is debatable, with ACCHA guidelines shifting blood pressure thresholds from 140 over 90 to 130 over 80. There may be changes in the future, but for now, it's over 140 over 90 when you've had at least 2 occasions documented 4 hours apart, or if you have systolic blood pressure over 160 over 110, and the presence of proteinuria. We no longer need to do those 24-hour proteinuria measurements for the diagnosis of preeclampsia because it just takes too long. You can do these other ways to measure proteinuria for indication for delivery. If you don't have that, there are also other severe features that count towards the diagnosis of preeclampsia with severe features: thrombocytopenia, platelets less than 100,000, impaired liver function, enzymes, renal insufficiency, presence of pulmonary edema, heart failure, brain organ injury, visual disturbances, headache. And the key thing is that once you have that high blood pressure, severe range blood pressures over 160 over 110, they're at higher risk of stroke and brain edema. And so you really want to start their antihypertensive urgently and start magnesium as well for the prevention of eclampsia, eclamptic seizures. What about your patients with chronic hypertension? So chronic hypertension is defined as if they have elevated blood pressures. Now, here we kind of use more of the ACCHA criteria of 130 over 80, diagnosed or present before pregnancy or before 20 weeks of gestation. Because as you saw that figure of looking at the timeline of blood pressure, really the blood pressure will increase significantly until after 20 weeks of gestation. In fact, the first trimester, because of the vasodilation that occurs, the blood pressure tends to drop a little bit. So some patients with chronic hypertension might not need their blood pressure medications in that first 12 weeks or so. If they have new diagnosis of hypertension during pregnancy, but they continue to have persistent hypertension after 3 months of pregnancy, that's also now called chronic hypertension. Usually those fluid shifts and hemodynamic changes should resolve. And so if you're still hypertensive after your 4th trimester, then we call that chronic hypertension. And then patients who have chronic hypertension who then, spike above their chronic hypertension and meet criteria for preeclampsia, we'll call that chronic hypertension with superimposed preeclampsia. So you may ask, well, where does that 160 over 110, come from? And it's really limited data, but this is just very small. You can see N of, less than 100, studies done many, many years ago to look at patients who actually had strokes in the setting of preeclampsia. And they found that most patients in this category who had strokes had blood pressures over 160 or over 110. So that's really how that threshold was determined. We have, most of our hypertensive tools for treatment are the labetalol orally if they're pregnant, as well as the long-acting nifedipine XL. We no longer really have access to methyl-dopa. Nobody is making that anymore. But one interesting trial that came out several years ago was looking at whether diuresing the patients would improve their blood pressure control. And this, there's been a few studies, but this is one that was published in Hypertension that showed that if you give Lasix for the first 5 days postpartum, that seemed to reduce their overall blood pressure numbers and the need for escalation of blood pressure medications. This seemed to be more effective in patients who did not have the severe range hypertension, however. And then another important trial, this was a big deal because you may think as cardiologists, like, of course, we're not going to let a person have blood pressures in their 150s over 90s, but actually for a long time, OB/GYNs were not treating hypertension unless they were over 160 over 110. And so this was a big trial led by Alan Tita and a whole group of investigators. It was an open label, multi-center randomized controlled trial to determine whether treating women with medications, this was oral labetalol and oral long-acting nifedipine, to target blood pressure less than 140 over 90, would have any detriment. So the OB's concern was that, well, if you lower blood pressure in pregnancy, there may be some abnormalities with placental hypoperfusion, and then you're gonna have adverse effects on the baby. So this trial was very important because it showed that not only did it was the intervention arm associated with reduced primary composite outcome, which was a composite of preeclampsia with severe features, medically indicated preterm birth, and other placental fetal death concerns, but also that actually there was no signs that the patients with lower blood pressure had smaller babies. So that has changed the way I think, for the first time, provide evidence to support treating patients with chronic hypertension at a lower threshold, less than 140 over 90, as opposed to letting them ride in their 150s. What happens after they deliver? Well, then we have a lot more options. ACE inhibitors, captopril, enalapril, benazepril, quinapril are felt to be safe in breastfeeding. While we usually don't start pregnant women on diuretics, if they already were on a diuretic preceding pregnancy, you can keep them on their diuretic. The thought is that if you start them on a diuretic during pregnancy, especially if it's a high dose diuretic, you might be worried about the volume of placental fluid. But ultimately, we will recommend it postpartum. You just have to let them know that they still have to stay hydrated if they want to sustain their milk production. Unfortunately, we don't have much data on ARBs, so we don't use ARBs for blood pressure control or heart failure if they want to breastfeed. You can see that amlodipine is not on this list because we still don't have that much data, but there are some studies now that have been published that show that it's safe. We just have to mention that to patients. Now, what about peripartum cardiomyopathy? This is defined as new onset non-ischemic cardiomyopathy with a reduced ejection fraction less than 45%. Usually occurs in the first months postpartum or in that last couple months of pregnancy. There are risk factors associated. Hypertension, preeclampsia is a major risk factor, gestational pregnancies, older age. And unfortunately, these patients are the ones that will say, oh, I'm just so tired. or I'm having the swelling, I'm short of breath, and often these are the patients that are dismissed as having just normal pregnancy or postpartum signs and symptoms. So having that heightened threshold to get a BNP, get an echo is important. Unfortunately, those who persist having a dilated left ventricle, particularly greater than 6 centimeters, lower ejection fraction, less than 30%, African American, are have worse outcomes. And we really don't have a good sense of like how long to treat these patients. This is a recoverable, cardiomyopathy with GDMT, but we do see that patients who might be prematurely discontinued on their medications are at future long-term risk for recurrent cardiomyopathy. Their ejection fraction can decrease, so it's recommended to stop the medications one at a time, repeat an echo in 6 months or so, and just monitor closely, because even though their EF may have recovered, they're at a risk for declining in the future. The medications, again, after pregnancy, we use beta blockers and enalapril, spironolactone very comfortably. These patients, unfortunately, who have a low ejection fraction are at higher risk for thrombus formation, so we will consider anticoagulation if their EF is particularly low. Some people will recommend, if their EF is low, to consider a wearable cardioverter defibrillator. I can't think of any women who actually kept with that. It's very uncomfortable. They're worried about breastfeeding, taking it off for breastfeeding, shocking their baby, etc. And then we do talk about contraception. These are patients that you would recommend an IUD. There is a current trial, multi-center clinical trial called Rebirth. I'm not sure if UCSF is participating in it, but it's actively recruiting women who are newly diagnosed with peripartum cardiomyopathy within 5 months postpartum and LVF less than 40% within 4 weeks prior to consent. The idea is to determine in a randomized fashion whether bromocriptine actually improves LV outcomes, LV ejection fraction. That's the primary outcome. There are studies that have come from Europe, from South Africa, that suggest that bromocriptine may help, but we really don't have a definitive answer. So this is actively recruiting. And what to do with these patients for risk counseling after pregnancy. Work from Dr. Al-Qayyam at USC has shown that those who have low ejection fraction, persistent low ejection fraction, unfortunately, are at a higher risk for mortality. So we don't recommend those women to get pregnant again. But if they do have full recovered pregnancy, you can consider pregnancy with close monitoring. This is just a kind of a potential way to monitor with serial echocardiograms and BNP in various stages of their pregnancy and postpartum. Lastly, in the last few minutes, I'll talk about acute myocardial infarction. Who has had to cath someone who is pregnant or postpartum? It's very rare, but we can see women with AMI, most often due to coronary dissection, but people, will have atherosclerotic lesions. And what's important for the interventionalists in the room is just that very careful engagement of the coronary arteries. In the pregnant state, postpartum, the arteries are more susceptible to iatrogenic dissection as well. So you want to be very careful during injection of coronary angiography. Make sure you're not engaging too deep and not using a very rapid bolus. But it is something that is a multidisciplinary effort. There are some patients, if they're really low risk, they might have a small troponin, very transient chest pain, and STEMI, where you may consider just medical management and not take them for, PCI. But if they have continuous chest pain, dynamic ECG changes, hemodynamic instability, then do pursue the coronary angiography. We don't yet have data of just how to incorporate CT coronary angiography into this. Some people are proponents of it, some people are not. It is an option to do, but again, sometimes you just can't diagnose the SCAD with CT coronary angiography, particularly if it's a small vessel. So you just have to note that limitation. This is just an example of a patient that we took care of who had multi-vessel SCAD. Pregnant postpartum patients are at higher risk for multi-vessel SCAD. So this was diffuse intramural hematoma of the LAD. You can just see that the vessels are diffusely narrowed. And then on the right side, what is a mimicker of coronary artery disease is what we call a type 3 SCAD, where it's more of a focal intramural hematoma. And for the RCA, it just looked like smaller lesions. Fortunately, we don't have to deal with maternal cardiac arrest too often, but the OB/GYNs do often practice resuscitation skills and scenarios in their sim training, because when you've got a pregnant woman who is unfortunately in maternal cardiac arrest, they have to prepare for perimortem delivery, and that's usually decided upon if they aren't able to resuscitate after 4 minutes. And then the other important thing is, if you happen to be in a situation like this, if they're pregnant, is to perform that manual left lateral uterine displacement, so between their ribs and their hip, push the uterus over to the left to remove it off of the IVC, so that there can be better flow, venous return. So take-home points. I hope you appreciate the significance of cardiovascular morbidity and mortality in pregnant and postpartum patients, understand some of the signs and symptoms that distinguish higher risk from normal pregnancy, and appreciate the need for a pregnancy heart team, which I am glad UCSF has, and just have low thresholds to think about the heart whenever you're seeing a patient with various cardiac symptoms, low thresholds for ordering BNP, troponins, ECG, and cardiology consultation, and particularly pay attention to that postpartum state, because it's be completely healthy, and unfortunately, due to all those fluid shifts postpartum, that first week to 2 weeks, higher risk for hypertensive disorders and heart failure. If you want any more resources in terms of these topics, there are various publications. The Cardio-Obstetrics Working Group published a nice series in JACC that talk a little more detail about the issues that I brought up. There are also the ACOG practice bulletin and other statements that have been published. I like to just put a quick plug about 2 things. Wearing my California ACC, I'm the Southern California governor. Medi-Cal is a big provider for our pregnant postpartum women, and unfortunately, Medi-Cal is highly under budgeted. There was something called the managed care tax that allotted billions of dollars for California that was dedicated to improving Medi-Cal reimbursement for our providers, cardiologists, OBs, primary care, emergency room settings. Unfortunately, because of the California deficit, our governor decided to, instead of allotting that amount to Medi-Cal, to divert it to balancing the budget. And so that was a big effort, advocacy for California ACC to try to block that. And one of the ballots on the ballot this November is Prop 35, which has been signed on by multiple medical associations, including ACC, to vote yes, because that's to try to protect this Medi-Cal fund. It's not adding extra tax. It's already been taxed by the managed care organization, but it's to protect that, to allow our patients to have better access. And then lastly, I don't know if our other colleagues, Jaya Malidi, is on, but she's leading with others a Women in Cardiology Career Development event. It's been a great collaboration with UCSF over the last couple of years. So please take a look and sign up. Thanks for your attention.
Thank you.